Hi, we are going to talk about obsessive disorders, um, and from the chapter um, in by Noyes and Brown, Munoz, and Stoffel. I left the L off. So, obsessive compulsive disorder first. Um, uh, It consists of two components. First is the obsessive thought. Um, I've presented this as an anxiety disorder, but Noyes separates the whole group out and puts it with itself. Um, those obsessive thoughts are recurrent, persistent, intrusive thoughts, urges, images that cause intense anxiety and distress. So it's not something that the person wants to be thinking. It is intrusive and unwanted. Some examples are of contamination, of harming other folks, scrupulosity, religious, moral obsessions, perfection related obsessions. I once had a postal worker that I worked with who had uh, obsessive thoughts about um, uh, things going awry, and I'm trying to remember what the obsession was. I don't. I remember the compulsions. Um, um, but he had a thought that something was going to go terribly wrong unless he had these rituals. And what the compulsions are repetitive behaviors that are intended to reduce uh, that anxiety. So it can be counting, hand washing, checking. There's a whole slew of them. For him, it was counting, and then he would have to touch things, and and that would relieve the anxiety, but it would come back, and so therefore he would need to go through this whole ritual, and the ritual got longer and longer until he could only deliver 7 pieces of mail a day. That's not enough to keep your job as a postman, um, which was how he ended up in the hospital where I work. So those are obsessive compulsive disorders. Difference between obsessive compulsive disorder and obsessive compulsive personality disorder um, is largely of extreme and insight. Obsessive compulsive disorder is that obsessive thought and then that compulsion that relieves the anxiety. Um, it disrupts occupations, uh, and those maladaptive habits and routines just take over. They can see that that's not working. That postman knew that this was not working, that this was not um, uh, typical behavior or expected behavior, and that it was going to get him in trouble. He knew that. Someone with an obsessive compulsive personality disorder, their identity often is tied to productivity, um, and they see that as that obsessive kind of attention to detail um, as functional. So they have very limited insight as to that personality disorder as a disorder. They see that as part of being productive. So also doesn't quite have the same kind of obsessive thought, compulsive behavior um, tie. Um, they just have an obsessive need for perfection. Body dysmorphic disorder. So in body dysmorphic disorder, people have a preoccupation with perceived flaws in their appearance. Variant is muscle dysmorphia, kind of having an ideal image of oneself. And no matter how much you work out, how much you do, that what faces you in the mirror isn't what you are looking for. Um, they may seek reassurance, use excessive exercise, steroids, excessive cosmetic surgery. Um, so think about women that you have seen in the news, or I have seen in the news, that have had so much surgery that they look like caricatures, with the really large lips and their faces are stretched away, and they have had just surgery after surgery after surgery, and they're still not satisfied, and won't be. And they have gone from very often attractive people to kind of this distorted features in search of that, aligning what they think that they want and the body that they see, and they just don't get there. Can be around weight, as well. Hoarding disorder, another obsessive disorder. People with hoarding disorder have difficulty discarding their possessions. They have varied levels of insight, may have issues of safety, because their environment has got so many obstacles in it, or depending on what they hoard, that things are just not sanitary. May have difficulty getting to the restroom, and into the shower, to take care of their basic ADLs. Forced cleanouts cause extreme anxiety and are not really effective, at all. There are some interventions, and we get to, if you look in your book on that table, there is one I know of, another that an occupational therapist with the VA has created some groups for people with hoarding disorders, vets with hoarding disorders, and it is a peer-to-peer support and kind of gradual process of letting go. But then trichotillomania, and excoriation disorders. So trichotillomania is pulling one's hair out. Generally, it's a response to stress. The trigger could be boredom or anxiety, but it is a compulsive behavior. Excoriation disorders are picking at their skin, which results in lesions in the skin. Both disorders are higher in women. They often start in childhood. They may occur together or with anxiety or depression. Aaron, with my son, my oldest son, picked at his skin. He was never diagnosed with excoriation disorder, but he sure could have been had somebody been diagnosing. He was in an extremely abusive treatment facility, and he began picking his skin as a dissociative response to trauma. So pain creates an endorphin response. And so sometimes self-harm for people who are in situations, traumatic situations that they cannot escape, is a way to kind of escape even though you're stuck there. And so he did that as part of a dissociative response. It persisted beyond the treatment facility almost as a habitual, probably again could have been diagnosed. Um, uh, but he kind of shifted that into tattoos, which became its own obsessive thing for him. So let's look at why. Uh, uh, Genetics. So OCD in particular has a strong genetic link, a strong familial link. Um, they're studying neuroanatomical characteristics. PET and fMRI studies suggest frontal lobe involvement, but a lot more study is needed there. Um, Neurochemical, uh, they target uh, serotonin because of its role in managing fear, and GABA because of its role in anxiety. Um, but again, that needs a whole lot more study. Medications that are used are uh, selective serotonin reuptake inhibitors, which basically, so one synapse lets go of the neurotransmitter, in this case serotonin, and the next one receives it. And then when it's kind of sated, that floods back into the synapse. I'm trying to get my hands in the right place, to into the synapse, and the neuron that was releasing it pulls it back in, and SSRIs keep that from occurring. So it keeps just more serotonin available in the synapse. And those are used with obsessive disorders. Um, Cognitive and psychological. So we talked about in OCD, the compulsive behaviors are a response to those obsessive thoughts. And so they tend to pair the that obsessive thought and the relief of that anxiety with whatever the compulsion is, and that compulsion just gets stronger. When I was a fairly new OT, I worked in a homeless shelter, and we had a fellow who was very tall and thin. He pretty much survived on Twinkies, and he began to have obsessive thoughts about hurting me, and came and disclosed those to me in graphic detail. Now, remember, these are thoughts that are disturbing to him. They're not things he wants to do. They're just intrusive thoughts that are coming in. And so he came and told me, here, this is what I'm thinking. And I said, you know, look at you and look at me. I could take you. That's not going to happen. And that relieved his anxiety. But what did that do? That just increased the link. So when he had that obsessive thought again, his solution was to come to me, and that's called checking. So that he had a checking compulsion, and he would come to me, and I'd say, "Ain't gonna happen," and that link became stronger and stronger, until it got to the point where neither of us were getting anything done in the daytime. It was ridiculous. And so we had a psychiatrist that came one afternoon a week, and I booked us an appointment and brought him in and said, you got to do something, Dr. Crumley. This is awful. It's not working. And he said to me, you are causing this. You are perpetuating, really, not causing. And so what I had to do was decouple that checking behavior as his solution. So he would come up, he would have the obsessive thought, he would come up and say, Betty, I need to, and I would have to just put my hand up and say, uh, nope, and send him away, which was distressing for both of us, because it was leaving him to his own devices, to self-soothe and let go of, and figure out how to deal with that thought. But that is the solution, and we'll talk about that in a little bit. So that's what I had to do. And then thinking about the environment, there are environmental risks, certainly. Trauma is a big one. Having trauma is a risk factor for all kinds of things, but certainly obsessive compulsive disorders. We've talked about sometimes it's inherited. That's the genetic piece, but in the environment, also trauma. And then there is a condition, PANDAS, which is an infection in childhood. It's pediatric, PANDAS stands for pediatric autoimmune disorder associated with strep. And the theory is that it's an atypical autoimmune response to strep that affects the basal ganglia. And that is another instance that causes obsessive compulsive disorder. And then racial discrimination is known to worsen symptoms. So being in a more stressful environment pretty frequently makes everything worse, whatever the condition. And one of the ways of managing things is managing stress well. But racial discrimination is known to worsen symptoms. So specifically, the book gives the example of a Black person who is hypervigilant around cleanliness, because of the stereotype that they are less clean. So they become really scrupulous trying to assuage the fear that people are thinking that about them. Excuse me. Evidence-based practice. So exposure and response prevention, which is really basically what I did with the fellow at the shelter, except for it's a little bit more controlled. It is systematically exposing the person to triggers while having them not engage in that compulsive behavior, which is very anxiety provoking. And so managing that anxiety without the behavior. So that exposure and response prevention, or ERP, and cognitive behavioral therapy, and medications. That combination is kind of the gold standard. Table in your text 21.1 presents 11 common approaches that range from creating environmental supports for occupation. So think the CAT certification that you are taking training in for lab. And it is listed there, cognitive adaptation training, to strategies that target cognition, to those that build alternative coping, and ACT, which advocates, or ACT, it's not ACT, excuse me, you should not call it ACT, that is something else, but it is spelled the same. You refer to it as ACT. It is acceptance and commitment therapy. And it advocates the acceptance of that. So just accepting, I'm having this obsessive thought, Um, and rather than fighting it, just kind of, it is just here with me. I'm going to choose not to act on it. So we'll talk about my postal carrier. I'm going to choose not to act on those compulsions um, because it is more important for me to be a mail carrier and be able to hold my job. Um, so uh, it involves identifying values and identifying your values and then um, looking at whether the behavior, the thoughts, because it's kind of a fusion of CBT, cognitive behavioral therapy, and mindfulness, looking at whether your thoughts are driving you toward your values or away from them, and how that's working out. We'll do some exercises in lab around that. So it's basically acknowledging the impulse or the want to, but choosing behaviors that support a more values driven goals. So considerations for you as an occupational therapist, um, uh, therapeutic use of yourself. So you build relationship, collaborate with the team, and talk to them about what's going on and everybody kind of get on the same page. Certainly with the individual. Um, Advocate for referral to specialty resources where those are needed. Another set of strategies are medications, which we talked about earlier, SSRIs. Um, as with refractory depression, there are brain stimulation techniques that are used when meds and behavioral strategies are not working. I do not know why I'm getting those dingy sounds when neither of those is working. One is electroconvulsive therapy, or ECT. And that is essentially inducing seizures, um, Um, and I don't think, have a good answer for why that works. I'm moving to get away from the dingy noise. Um, they don't have a good answer for why that works. Um, but it often does. And so, same as with really refractory or depression that is not responded to all of the other evidence-based kind of tools for it. Um, it is quicker often than many of those things. But that is one ECT. Better yet is a newer strategy, which is repetitive transcranial electromagnetic stimulation, or small r TMS. And that is a procedure where they put probes on the outside of one's brain. It's not surgical. And use electrical pulses. It is non-invasive, and it is effective for sometimes for obsessive disorders, and again, depression, uh, as a minimally invasive kind of strategy. And then there is deep brain stimulation, which is neurosurgery. So that would be a last ditch disorder or disordered strategy for obsessive disorders. So thank you.
recording. Why?